morning, and thanks one more time to the uh, Society for Family Physicians. I enjoyed the first talk very much, and I just want to say this is what we used to do without computers. But since then, we have all been adulterated. And something which adulterates us from generations and centuries was alcohol. So I bring you greetings from the Institute of Liver and Biliary Sciences. That's deemed to be liver university, the only global liver university, and a WHO collaborative center. Why I chose this topic was basically that it's a huge problem and you people are the first point of contact. I have nothing to disclose except that we have very bright residents who come. We run 17 courses on liver who come across the country, and Raman is one of our very favorite person who helps us in understanding what people need it in general practice. This is our young faculty, about 62 of them, each very bright and smart. So one of the oldest recreational drugs and socially accepted is a hepatotoxin, and we have a huge growth in this industry. This is not to bore you, but it affects all organs, from your brain, parotid. So the moment somebody comes, has parotids, we have two diagnoses. One is alcohol. What is second? It's obesity and fatty liver disease. So the moment somebody has the first differential diagnosis is, so the person walks in, he weighs 68 kg but has parotids. I'll say he's a lean NASH. We ask the history, is your father diabetic? Yes. Your mother diabetic? Yes. So he's a manufacturing defect. Parotid is the first gland which tells you fat in the liver or alcoholic liver disease. So it's very important as a clinician to have this differential diagnosis. Of course, alcohol affects heart, it affects your bone marrow, osteoporosis. So you all keep pumping vitamin D and calcium. And day before I saw a patient who was having nothing else but a small hemangioma of the liver, was admitted in the night with a calcium, corrected calcium of 18. He was given calcium twice a day. Then we asked, why has it gone so high? He went for emergency dialysis because he has prolonged QT and had a cardiac dysarrhythmia. We said, why? He has been drinking alcohol and had osteoporosis. So he went to the doctor and he was given high dose of vitamin D, all the shots, which I recommend you not to give every time, and also not to give calcium for more than 3 months and not to give twice a day generally. So this guy, especially if he is an alcoholic, so understand the cause of osteoporosis is not his other problem, it could be alcohol. Of course, you know that sexual dysfunction and other things can happen, and alcoholic gastritis is your own doing. I'll not go into details, but just to tell you that tumors are also associated. We get people who come with GI bleeding, and that bleed is because of the tear, Mallory-Weiss tear. I just want to concentrate on two things. One is alcoholic hepatitis, and also to tell you alcohol leads to a lot of malabsorption, and therefore remember this, that malabsorption, one of the causes is drinking alcohol. I'll not go into details of cardiovascular, nervous, hematological I told you, and other causes. So everyone wants, whenever we give this talk, how much is risky? How much is too much? All of you know it, no? As doctors, how many of you drink? Can you raise hand without inhibitions? Very few. It's too civilized a crowd. Do you believe? Should we take it as granted? So I'll tell you a story of a young girl. She was drinking alcohol almost like a fish. She was 26. When she came to us, she had no alcoholic hepatitis, but she was pregnant. And when she was pregnant and she continued to drink, and what is that syndrome called? Fetal alcohol syndrome. Her baby was born like, an acidotic baby, and the baby died. That was the time she left drinking. And then she and her father asked, what is a safe drinking limit? And the safe drinking limit for women is half of men. She was actually always reading the drinking limit is 2 drinks a day, and she would go to 4 or 5 drinks a day twice a week. So she said, I am quite okay. But the effect on the fetus was so huge that she got a stillbirth and acidotic baby. So I want to tell you how much is an individual variability. In general, 1 drink for a day for a woman. And what is 1 drink? Is about 14 grams, 12 to 14 grams. You can calculate that. But here is the problem. Somebody is obese, somebody is 45, and somebody is diabetic. This goes down by half. So to give an example, somebody who goes to Delhi Gymkhana in the evening, he is 45, he is obese, he is diabetic, and he drinks 2 pegs in the evening. This is too much. His chance of liver disease is 16 times high. Pure alcohol, let's say the risk is 1. Alcohol plus obesity is 2 times. Alcohol, obesity and diabetes is 4 times. And if he is above 45, it multiplies. His risk of cirrhosis or liver cancer increases by about, and now he has hepatitis B or C, or he is taking drugs for something like paracetamol. These risks increase hugely. I've already told you about pregnancy. So therefore, this is a huge individual variability. Of course, there are family problems. I will not go into details. Divorces. Now, this is important for every physician of us. A patient comes, you ask, do you drink? Yeah, but I have never drunk enough. The first answer is, I haven't drunk. I have yet to find a single patient who says, sir, I drink too much. They all say, I wish I could drink more.
I am within limits.
With that problem, how do you assess the level and pattern? And it requires some understanding. I cannot tell you. I am a liver specialist. But since I have been seeing these alcohol patients for over 30 years, I can just tell you, don't ask the wife, ask the man direct, straight questions. After 2-3 times, you win his confidence and he will tell you straight, neither his wife nor his family. And you must have an eye-level contact with him. So you find out what is his level of drinking very carefully and his dependence. There are all these scores, I will not go into details, and the consequences. One of the important things we used to think is tremors. But tremors only come if he has drunk last day or last 1 week. They won't come if he hasn't been drinking very, very recently. There are several scores, I will not go into detail, just to tell you audit, CAGE are the major names. Now this is important. What we call alcohol use disorder, maladaptive pattern, and this is for last 12 months. This is where family must be asked, are you okay with your husband or with your wife? Generally will say yes. Do you think he was better a year before? That one answer will tell you yes, he was probably better. That's enough. Then about his job, role as a failure and any bodily harm. This is enough for us. Recidivism is a huge problem. So we do a lot of transplants, about 300 liver transplants done in the Liver Institute. Our major problem is, and I'll come to it one more time, is recidivism. The guy drinks alcohol, wife gives the liver, he gets a liver transplant. It's always generally the wife or the son or the daughter. but generally wife. After that, he goes back and fights. He starts drinking again. And now the new liver, under immunosuppression, becomes cirrhotic in 2 years or 3 years. His bilirubin, which used to be 5 or 10, now comes with 50, 60, 70 bilirubin. Recidivism is a huge problem, pre-transplant or post-transplant, or in a normal person. Which is the best drug for that? I want to give you one tip and you use it. This is the best drug, that is baclofen. Baclofen, this is a large lancet paper. If you use no, recidivism is high. If you use baclofen, it comes to 20%. 4 out of 5 times, baclofen will help you. And we give 10 milligrams 3 times a day. Sometimes we add with this Librium in high dose. So you can use Librium plus baclofen as the drug of choice for your patients. Now something about alcoholic liver disease. I want to show you this graph. This is when I was working at GB Pant in 1980s and 90s. Hepatitis B was 50% of cirrhosis, and hepatitis C and alcoholic liver disease was 15%. Today at the ILBS, 44% of our patients are alcoholic liver disease. Almost half of the patients have alcoholic liver disease. When somebody comes with jaundice and deranged coagulation, what are the causes? If you see that hepatitis B is just 15% of the 1300 patients that we see, what we call as liver failure, who need liver transplant. Out of 1300 patients, 200 are hepatitis B, 780 are alcoholic hepatitis. And right now, 60%, 70% of the institute is filled with patients who have alcoholic hepatitis. Females, in 1 week we would see one female coming, 20 years, 25, they were modeling or whatever job, and they come with severe alcoholic hepatitis. There is no one to give them a liver also. It's a huge challenge for us. So I think, if you agree with me, please remember, alcohol is the number 1 liver insult which requires admission. And who can protect, who can prevent? Maybe only you. What alcohol does? First, it's a normal liver which has all these good sinusoids and the hepatocytes in cords. The blood comes, but then it gets fat in the liver. The excretory capacity of the liver goes down, so fatty liver develops. Then it can develop into alcoholic hepatitis, which is jaundice and fatty liver. And then liver gets fibrosed, then there is cirrhosis, and then liver cancer. So those who drink regularly, as I said, nearly 100% will get fatty liver. Only about 30% get alcoholic hepatitis. Now the question is, I only drink, but my chance is 1/3. Why should I? So I want to give you a story, which is a real life story. In early 80s, a Sardarji came to me, 35, 40-year-old, and he had blood vomitings. This blood vomiting, we did endoscopy, put bands and all that, and stabilized. Deep jaundice. Transplant was not available in India. So I asked his father, you never stopped. He was a Sikh gentleman, a heavy 70-year-old man. I said, you never stopped this guy from drinking. What have you done? Aji, mera ladka hi nahi hega. What surprise, yeah. Your son name is written. He says, he is not my son. I said, why? He says, look, for me, I have been drinking for 50 years, 1 bottle a day. This guy has only drunk for 15 years, half a bottle. He is not my son. I got very confused. Yeah. 50 years, 1 bottle a day. And he has drunk 15 years. When was he born? He was born, he's about when 22 years or something like that. I said, look, your 20 years of drinking made your genes high like this. Then his drinking for 15 years makes 30 years of drinking. This is called walking gene theory. If your parents are diabetic, you are a manufacturing defect. If your parents are alcoholic, you are a manufacturing defect. Because your genes are already produced with something where drinking has been for 15 years. So this gentleman, for 15 or 10 years of drinking, what his father did not get for 50 years of drinking. I hope I give you the message. The walking gene theory, and therefore, who will get liver disease? Somebody who has a predisposition. If you continue to drink, you get cirrhosis. I don't want to tell you a trade secret, but if you want to reverse alcoholic fibrosis, the best drug is coffee. But don't tell everybody. How do you define alcoholic hepatitis? Very complicated for people because everyone diagnoses differently. But if the AST, that is SGOT, is more than SGPT, AST is more than ALT by 2 times, SGOT 200, SGPT 100, alcoholic hepatitis. Bilirubin is more than 5. INR, earlier we used to call prothrombin time. मेरा PT 12 है, पेशेंट का 18 है. दोनों का डिफरेंस वी यूज टू कैलकुलेट. नाउ इट इज़ एन इंटरनेशनल नॉर्मलाइज्ड रेशियो, बट यू कैन गो टू द ओल्ड स्टाइल. And his TLC count is high. That is alcoholic hepatitis. So all of you can diagnose it. Simple. High bilirubin, high INR, high SGOT, and high TLC. So the patient, when he comes to you, he has jaundice. He has a liver which is tender and large. Sometimes he may have ascites. And AST is higher, but not higher than 300. I also want to tell you, one patient was airlifted from Pune or that area for liver transplant. He was a IIT student. II Pune, one of the institute student. This guy was drinking and had fever. He was given 4 tablets of crocin. Nothing major. His SGPT went to 10,000 something. Can you explain why it goes that high? Paracetamol toxicity. If you and I take 4 tablets of paracetamol, nothing happens. But an alcoholic takes 4 paracetamol in one day, he is finished. So I want to remind you that the upper limit for a normal person of paracetamol is 20 grams. You can go up to 20 grams before liver failure sets. For alcoholic, it is 2 grams. And it is advised never to use more than 2. Give it only 1 gram. This fellow came, by the time his kidneys failed, his liver failed, no transplant, he died. Just because somebody for fever gave him 4. Another person I remember shifted from Ranchi. Another engineering student, he was fighting with his girlfriend, took drinks and then paracetamol. By the time he came, we couldn't do anything. The whole family was finished. So upper limit of paracetamol is this. So why I am telling you, if it goes very high, AST is thousands, it is liver failure. It is not alcoholic hepatitis, it is liver failure. You have liver which has huge amount of Mallory bodies, I hope you remember. All these are areas of necrosis, big ballooned liver cells, and these are dead, dying liver cells. And then fibrosis sets in, the liver gets scarred. And what is the unique part of alcoholic liver disease? Every cell, this is a hepatocyte. After every hepatocyte, there is a fibrosis. This is called chicken wire, जैसे जाली होती है, chicken wire fibrosis. This is so unique of alcoholic liver disease. There's only one differential diagnosis: NASH or fatty liver disease. Fatty liver disease and alcoholic liver disease are almost similar in their presentation. Your differential diagnosis is viral hepatitis. What happens in viral hepatitis? SGPT is higher than SGOT. In alcoholic hepatitis, SGOT is higher than SGPT. Just one reversal. Higher SGPT, viral hepatitis; higher SGOT, alcoholic hepatitis. Drug-induced liver injury, as I told you, is another differential diagnosis. Now, how do you assess how severe is the disease? Very simple formula, and I want you to note it down if you can. This is called DF. Suppose the patient's prothrombin time is 18, normal is 12. What is the difference? 6. 6 into 4.6 plus bilirubin. So 4.6 into 6 is something like 27. His bilirubin is 5. This makes it 32. So 4.6 into difference in prothrombin time plus bilirubin level. Moment it is above 32, send him to a specialist. Means he has coagulopathy and he has got liver failure. This patient should never be handled by you. He should be in a specialized liver unit. And his mortality is high. Such patient, 50% will die in 1 month. So your time is very short. How do you treat? 2 drugs, steroids or pentoxifylline. You know what is pentoxy? Trental.
Dental port.
You give it for vasodilation, increasing the circulation. The third drug, which I am not mentioning, is raw turmeric. Raw turmeric is the best anti-TNF, pentoxifylline drug, and that's why we say kachi haldi, which is science, huge science, is very good for us. What is the other drug? Coffee, which is a phosphodiesterase inhibitor. So 2 things can help an alcoholic or a liver disease patient: coffee, raw turmeric, and of course 2 drugs, corticosteroid and pentoxy. So when you give a steroid or you do not give a steroid, if you give steroid, so many patients, 79% of the patients may survive. If you do not give steroid, 65%. The advantage is about 10 to 12%. But the problem is these patients develop infections. On admission, so many have infections already. 25% have infections. And when you give steroids, many more lung infections, other infections can develop. This is the new trial published in New England Journal. I am not telling you to remember everything. This is called Stop Alcoholic Hepatitis. What it shows you that at 28 days giving steroids makes the drug better, makes survival improve. But at 90 days it does not improve. Just want you to remember, steroid gives you a window of 1 month of improved survival. After that he will die. In that time either you transplant or he will die. So we are back to basics. No drugs for us for alcoholic hepatitis. The basic is prevent, assess the patient early enough and try and see that it doesn't go to liver failure. I really get pained. Every week nearly 50 odd patients of alcoholic hepatitis would come where you can't do anything. And there is no other disease in my mind which has so much controversy. The controversy is liver transplant.